Hello and welcome at PCR 2025. My name is Philipp Lurz and I'm delighted to be joined here today by Mayra Guerrero and Modine. And the three of us, we will discuss today the latest developments in the field of mitral therapies. Before we do that, maybe we have a short look into the past. Thomas, what do you think are the key aspects which have been achieved and what is still missing in the field of mitral therapies?
So we know that transcatheter repair using edge-to-edge therapy is effective and safe. We lack some follow-up. We know that there are some patients who cannot be treated effectively by using edge-to-edge repair, and they need other alternatives like TMVR, like annuloplasty, like NeoChords, which are under investigation now. This is where we come from.
So there is a need to have something else than TEER, and we are all excited that finally we do have a replacement technology now available, transcatheter, transseptal. Mayra, what does that bring to the field for the patients, but also for the therapy overall?
Thank you. Well, I think it brings something to the present right now and also to the future. I'll tell you in a moment. To the present, it brings us an option to treat patients with better efficacy in terms of the reduction of mitral regurgitation. You see the results. Transcatheter mitral valve replacement, whether it's transapical or transseptal, it virtually eliminates mitral regurgitation, and that's associated with improvement in symptoms, quality of life, and at least in some of the transseptal therapies with favorable remodeling. And what also brings to the future is the opportunity to treat again with the valve-in-valve a decade later, if it fails.
Do you think it does expand the population, so patients who cannot benefit from TEER at the moment, or is this only a small proportion of patients?
Absolutely, absolutely. Patients who do not have anatomy that is favorable for TEER, they can now be treated with transcatheter mitral valve replacement. An example, MAC population. But even in non-calcified valves, there are some anatomies in which you cannot get a good result with TEER. Now those patients can be treated with replacement.
So TEER can be challenging, replacement might be easier, but obviously there is still a learning curve to go through. Thomas, in the future, do you think that every good mitral program should have both repair and replacement technologies?
I mean, if we are got inspired by surgical practice, I think any operating room or any catheter lab should have both of the technologies, because the idea is to be able to offer the patient both therapies appropriately based on anatomical clinical features. So the thing is how a team can adopt all these therapies in terms of imaging, in terms of skills of implantations themselves. But definitely we need to have both on them, because there will be no bias in terms of decision. The decision should be only driven by the interest of the patient and what is better for the patient himself.
Absolutely. So as always with these things, it is great news that we have repair and replacement, but it brings new challenges, because now we have to make a decision and decide on who should undergo repair and who should have a replacement. What are your thoughts to that?
Well, it's a good problem. Before we didn't have this option, so it's a good problem. I think we need to take in consideration anatomy, of course, but also age, or better yet, life expectancy. For example, an older patient who has multiple comorbidities and the life expectancy may be shorter, and who has problems tolerating anticoagulation, for example, which is required for the transcatheter replacement. Maybe those patients, if the anatomy is favorable for TEER or any other form of repair, could be treated or should be treated with repair. But a younger patient who has a longer life expectancy and who has otherwise no contraindications to anticoagulation, and in whom you want to get the best result, a replacement may be the best option. Particularly the anatomy is not ideal for TEER.
So replacement might be the bigger invest initially, but also something which lasts longer and gives more benefit in the long term?
Well, I do worry that if you leave a patient with unfavorable or not enough reduction of the mitral regurgitation with TEER, and that closes the door to future interventions, you're going to leave that patient for the subsequent years with a suboptimal results, versus you go with a transcatheter replacement where you have a predictable, reproducible result. You know that you're going to have 1+ or less, most likely less mitral regurgitation, most likely no mitral regurgitation. And you know that it's going to last for several years. And if it fails, you can treat again with transseptal mitral valve-in-valve.
I mean, so far, the TMVR innovations have been almost on pause, encouraged by the latest outcomes, for example, after COAPT and some other studies. But during follow-up, we have seen some disadvantages reappearing again, and out of which, as you have been saying, eliminating completely mitral regurgitation, opening the door or keeping the door open for TMVR. So I think we are reconstructing this landscape of mitral transcatheter treatments today based on all what we have learned in the past.
It's a great discussion. It seems that we are certainly at a turning point in the field of mitral therapies. We have summarized all the learnings, but there are still huge limitations. But luckily now innovations are coming into the field. We have the opportunity of replacement, which might also be the opportunity to standardize mitral therapies a little bit more. But what will be absolutely crucial is to have a safe and steep learning curve, and this is always as a group learning. Thank you.